Good afternoon, everybody. Marty Goldman. Welcome to our first Dr. Sharma Visiting Professor Program and Ananda Sharma Visiting Professor Program for this academic year. We picked a really very exciting topic and a great panel and a great visiting professor. Dr. Fuster will give us more details in just a few moments. I just wanted to tell you next month, October 10th, 2016, Dr. Edelman from Harvard MIT will be our visiting professor. The topic will be absorbable stents. We have Dr. Hill in November, Dr. Harrison in December, Dr. Gordon Tomaselli from Johns Hopkins in January, Philip Greenwald from Northwestern in February, Michael Gold in March, Jennifer Hall in April, Dr. Gersestein in May, and Dr. McNally in June. Very exciting panel of people coming for this coming year. I just want to tell people also next Monday on September 26th, Dr. Vivek Reddy is going to have a panel discussion here, 7:45 in the morning. Panel discussion on controversies in atrial fibrillation. So that should be very exciting as well. I just wanted to briefly mention the people who are going to be on the panel. It should be a very exciting, dynamic panel. We're privileged to have Dr. Krakoff, expert in hypertension, professor of medicine, Mary Ann McLaughlin, medical director, cardiac health program, assistant professor of medicine, health policy, geriatrics, and adult development, Jeffrey Mechanic, clinical professor of medicine, who we traded for from the endocrine department, who's now joined the cardiology department, Clive Rosendorf, professor of medicine, renowned expert in hypertension, Robert Rosenson, professor of medicine, director of the cardiometabolic disorder, Don Smith, who's an endocrinologist, associate professor of medicine, director of lipids and metabolism, and Kimberly Hung, who's the fellow who's going to present a monograph. Kimberly, this is one of the most difficult subjects to try to coalesce into a single topic, and she's done a fantastic job.
All right. So thank you, Dr. Bott, for coming to visit us today. It was a fantastic day. So I'll just start by kind of summarizing the epidemiologic data that we have so far in terms of cardiovascular disease. So cardiovascular death rates have continually decreased over the past 3 decades. However, even with these improvements, cardiovascular disease is still responsible for nearly 1 in 3 deaths in the United States and remains a primary cause of mortality here. Furthermore, the rate of decline has slowed, with there being a 40% decrease in mortality between 1980 to 2000, and only a 30% decrease between 2003 and 2013. Diminishing returns from advances in current treatments may explain part of this. However, the increased prevalence of other risk factors, including obesity and diabetes, is likely driving this as well. In fact, the prevalence of cardiovascular disease is estimated to increase by 10% over the next 20 years, even though outcomes have continued to improve. These trends suggest that there is a significant opportunity for impacting public health through just a primary prevention of cardiovascular disease by targeting its risk factors. In fact, one study found that nearly 50% of the decrease in mortality could be attributed to risk factor modification alone, and in particular, improvements in blood pressure and cholesterol management. Prevention is divided into primary prevention, which refers to the modification of risk factors associated with disease development, secondary prevention, which refers to the control of disease progression once present, and lastly, tertiary prevention, which refers to mitigating consequences of advanced disease on functional status and quality of life. A 4th category, called primordial prevention, first mentioned in 1978 by Strasser, refers to achieving a state of health that prevents risk factors themselves, and is a powerful concept that refers to preserving a time zero before disease can even begin to develop. While the opportunity for societal benefit is the greatest here, this involves cultural and population-wide strategies, which because of their scope may be the most difficult to achieve. From various epidemiological studies that have been conducted over the years, diabetes, hyperlipidemia, and hypertension have been identified as significant predictors of cardiovascular disease, and resultantly are featured prominently in various risk calculators. In addition to there being significant pathophysiological interplay between these three risk factors, another common denominator may be their effects on the coronary microvasculature. Coronary microvascular disease refers to the dysregulation in prearteriolar vessels that was first described in 1985 to explain anginal symptoms in patients without overt macrovascular disease. Postulated mechanisms for coronary microvascular disease that are shared between hypertension, diabetes, and the metabolic syndrome include endothelial and smooth muscle dysfunction, dysregulation of nitric oxide synthesis, as well as the production of growth factors, including angiotensin and endothelins. A potential opportunity for averting the significant morbidity and mortality associated with cardiovascular disease may be targeting prevention efforts at a stage before microvascular disease has developed. Preserving a state of health before the onset of subclinical cardiovascular disease is modeled after the concept of primordial prevention and clearly has the greatest potential for decreasing morbidity and mortality. This idea of primordial prevention and regression of disease is what drives the efforts to target lower and lower levels of risk and disease-specific targets. Additionally, there is also increasing evidence that lifetime exposure to these risk factors contributes significantly to risk as well. This phenomenon was shown in Mendelian studies looking at PCSK9 loss of function variants, who have a disproportionately lower lifetime risk for CHD compared to those obtained through clinical trials. A meta-analysis of these studies showed that lifelong exposure to lower levels of cholesterol conferred a threefold greater risk reduction than treatment with statins started later in life. While the theoretical benefit of targeting individuals earlier or even pre-disease is attractive, the side effects of treatments and physiological barriers will make the risk-benefit ratio unfavorable as we move towards a lower risk population, as well as lower treatment thresholds within these populations. Specifically in hypertension, a J-curve relating poor outcomes at both high and low blood pressures has been shown to exist in individuals with overt coronary artery disease. The pathophysiological explanation for this is that coronary perfusion is dependent on diastolic pressures, and as diastolic pressures fall, the perfusion is compromised, especially in the presence of atherosclerotic plaques. In diabetics, hypoglycemia has been similarly associated with increased cardiovascular events. The postulated mechanism for this is increased adrenergic activation and the associated increase in heart rate, systolic blood pressure, and cardiac output, which can exacerbate ischemia in at-risk vessels. The relevant issue here is identifying an intervention time before these risk factors have resulted in the vascular and end organ remodeling that confer an increased risk for these adverse events. Because atherosclerosis begins with the deposition of lipids in the vascular wall and is mediated by disturbances in homeostasis of cholesterol, statin therapy has also become an important therapy for preventing cardiovascular disease. The negative impact of low LDL levels is unclear. From a biological perspective, neonatal levels of LDL have been measured to 39 milligrams per deciliter and has been postulated as a physiological lower limit. Thus, unlike intensive blood pressure and glycemic control targets, where the effect of the medications, meaning hypotension and hypoglycemia, are the primary barriers, the adverse effect of statins, including diabetes, myopathies, and possibly increase in hemorrhagic strokes, will limit statin therapy. A shared concern affected by medication side effects are also how they will affect adherence and medication continuation. Regardless of whether hypertension, diabetes, or hyperlipidemia is targeted, the individual clinical characteristics of a patient will determine the thresholds of the treatment. A large part of this will be accurately discriminating between an advanced disease state that will inevitably evolve into overt coronary artery disease and a reversible disease state where aggressive risk factor modification will cause regression of maladaptive vascular and end organ remodeling. Because of this and the significant interplay between the diseases, as well as the redundancies in the pathologies behind the diseases, there is a movement towards treating cardiovascular disease risk and not just the separate disease entities that make up this risk. So, the primary prevention of cardiovascular disease through the control of blood pressure, glycemic levels, and lastly, lipid profiles will be the topic of tonight's discussion, with a specific focus on how early prevention efforts should start and what the therapeutic targets should be. So, cool. Thank you.
Again, that was just a small part of what you'll get to read if you pick up the monograph. Let me take 2 minutes to introduce, and I apologize if I embarrass Dr. Fuster, but at least once a year it's important to do this, just that people appreciate how lucky we are to have him as our director, as really the moderator of a panel. And not only does he moderate the panel, what's important is that he's taking care of patients, that he has direct impact on managing the patients based upon how he discusses them here, how he interrogates the panel. Let me just tell you a little bit about Dr. Fuster. He's director of Mount Sinai Heart, physician-in-chief of Mount Sinai Hospital, director of the Zena Michael Wiener Cardiovascular Institute, Maria and Josie Kravis Center for Cardiovascular Health, Richard Gorlin Research Foundation professor. He's been over the last year and a half editor of JACC, and past president of the American Heart Association, past president of the World Heart Federation, and a member of the Institute of Medicine, National Academy of Science. In his native Spain, he's a director of the equivalent of the NIH, which is actually probably unique in that it coalesces the major investigators from throughout Europe to do investigations and studies on major impactful aspects of cardiovascular disease and prevention. He has over 900 refereed papers and has edited numerous articles, both for JACC as well as Circulation, as well as every major journal that we read. Without further ado, Dr. Fuster.
Thank you, Martin. It seems like I am the visiting professor here. Thank you very much. I appreciate it. Well, it's certainly a privilege to introduce Dr. Deepak Badri from Boston, from the Brigham and Women's Hospital today, and I'm going to say a few words about him. He's certainly an outstanding person in every context of the world. He was, he obtained his Bachelor's of Science at MIT, and then Doctor in Medicine, Cornell University, and Master of Public Health at Harvard University. He has his postdoctoral training, internship, was at the University of Pennsylvania, and so his residency. And then he moved to the Cleveland Clinic, where he was a fellow in cardiology and interventional cardiology. And from there, this was about in 2001, he became attending physician at the Cleveland Clinic and was a staff member in the Department of Cardiovascular Medicine. And then was in the year 2008 that he moved to the Brigham and Women's Hospital. And in that, he became director of the Integrated Interventional Cardiovascular Program at the Brigham, as well as at the VA Boston healthcare system. Now, eventually, he got a number of jobs, first as a senior investigator of the TIMI study group at the Brigham, then as a senior physician, and then certainly at present time is in the board of advisors of the Brigham and Women's Hospital Heart and Vascular Center. Now, his curriculum is quite impressive. First of all, he has participated in a leadership role in so many committees, 35 committees locally, 110 committees nationally, and 15 committees internationally. So it's quite really of an accomplishment of people who like to have him in committees. For example, when I have to look for a good associate editor at JACC, I call at him, and he's actually one of the committees that he belongs to. Actually, he plays a role in the editorial board of 50 journals. I've never heard you this. And he's doing an incredible job. I have seen Deepak, how he reviews the papers, how he manages the papers, and always in the very honest and high ethical standards. It's absolutely incredible. Now, if I go into the awards, you know, he got awards everywhere he has been. He started already at Cornell University, a Stigler Scholar, then Outstanding Academic Achievement, also there. Then he moved into Cleveland, the same thing. European Society of Cardiology, Young Investigator Award in Thrombosis. And then the British Medical Association. Well, he has so many awards, and so it's just to give you a sense of the individual we are talking about. In terms of, he has the Eugene Brownwell Scholar at the Brigham, and Golden Heart Award from the VA Hospital, Boston Healthcare, and Distinguished Clinical Research Achievement Award on the AHA Stroke Council. Well, what is most important is he has been an incredible contributor in the field. In the field of almost every aspect on the cardiovascular science he has been participant on. He certainly has been very involved recently in the thrombotic aspect, thrombosis and atherosclerosis and issues of bleeding. Many aspects of intervention, but basically he has about 800 papers related to the topics that I am discussing. So I think we have with us today a very accomplished individual who actually choose a topic that to me is a topic which is quite challenging, and that is related to the primary prevention, which is not easy. But anyway, I'd like to give thanks to you, Deepak, for coming today and be with us and with the fellows. And let me give you this plaque from us in terms for your outstanding contributions and the Anandi Sharma Visiting Professor and the Simon Dag Memorial Lecture. Thanks for coming. Thank you. Good. Okay, Deepak, if you can sit in the middle, and then we have here a group of incredible panel, Mary McLaughlin and Jeffrey Mechanic, Cliff Rosendorf, Robert Rosenson, Don Smith, and certainly Kim. It's going to be difficult to stop this panel talking, so we have to really put breaks here. So every answer has to be maximum 1 minute. Otherwise, this is not going in. And the subject is quite challenging anyway. So the subject is actually focused on primary prevention. And Deepak, I want to ask you the first question. The last document on primary prevention from the European guidelines is actually 6 weeks old. The last document on primary prevention from the United States is in 2011. What is wrong here?
Well, that's a terrific and insightful question as always.
It's a terrific and insightful question as always, Dr. Fuster. But before I answer, I just, after that extremely warm introduction, have to say thank you to you and to the audience and the entire Mount Sinai family. It's really an honor and a privilege to have been invited back as a visiting professor, in particular as a Sharma visiting professor and the DAC lecturer. That means an immense amount to me. So thank you all for that singular honor. And furthermore, I'd say, Dr. Fuster, thank you personally for all the opportunities that you've afforded me through my career ever since I first met you as a resident when you were a visiting professor at Penn, and the huge impact you had on me as I had the good fortune of sitting next to you at the lunch, the fellows lunch at the University of Pennsylvania. So from then on, thank you for all the advice and kindnesses. It's truly appreciated. As far as the guideline question, are we taping this, by the way? Or, okay, no. In that case, I can speak for. There's.
In your case, you will have a minute and a half. The others will give you 1 minute.
Then I'll be quick. The Europeans are ahead of us a lot of times when it comes to the guidelines. We spend a lot of time thinking and talking and worrying about conflicts and all sorts of other things, while the Europeans are actually producing very clear guidelines in a timely fashion. So that's the explanation. We need to do a better job in the U.S. Producing guidelines, keeping up with the data, and then getting those guidelines out to physicians.
Thank you, Don. It is curious because the guidelines in the United States about primary prevention appear to be completely dichotomized. Now we have diabetes. The next year is cholesterol. The following year is pediatrics. The following year is this the way we should approach a patient in terms of primary prevention?
Absolutely not. I mean, it really primary prevention, all aspects of patient care, but especially so primary prevention should be patient-centric. And the way the guidelines are sort of balkanized, and there's just so much passion and opinion about each little aspect. In the end, I don't think that's helpful for patients. What's really needed is a global integrated approach to the patient and reducing their cardiovascular risk. And looking at each of these different risk factors separately, it's an interesting academic exercise, but not a useful clinical one.
Don Smith, can I ask you, you are a very fantastic physician, I must say. I know you for so many years, and it's interesting because your main interest is such lipids, but every time you see a patient, I'm amazed, but you take care really of everything, blood pressure, diabetes, and weight, exercise, and so forth. And I think it's the question that we were addressing right now. Why in this country, we tend to just focus obsessively what is the level of cholesterol and what is the level of blood pressure and what is the level of this and that, and we don't look more in an integrated way.
I think it's because of medical specializations. We all group together in our own special interests. We don't simply have, it's too hard to know everything about all three put together. In fact, the fact that Kimberly could put together this is amazing. So I think that's the problem. We don't think about lifetime at all. We think about 5-year intervals as opposed to starting much earlier and beginning on many different things to try to prevent. So, but I think it's part of the unfortunate division of specialists within the United States.
I hope this will change, isn't it? As we move into primary prevention, let me ask Jeff. Jeff, there is a trend in moving very rapidly from actually treating disease, which we'll always treat, to the promotion of health and preventing of disease. And it is in this context that I would like to make a statement and see if you agree or disagree.
I agree.
All right, thank you very much. So we'll go to another question. The issue is that it seems that the fact that mortality has decreased in this country is 50% by taking better care of ourselves, maybe hypertension, maybe lipids, and so forth. But the other 50% is a tremendous expenditure that we have with disease. I have the figures here. I'll give you figures right now. And in Europe, in 2014, $150 billion were spent in treatment of cardiovascular disease. And in the United States, $300 billion, about 2 years ago. So, and obviously, the projection of this is going up because we have more technology and we don't allow patients to die. What is your view of this? I mean, because we need to really move very rapidly. And this is why I like the topic today, although I must accept it's a very difficult topic, Kim, as you realize, to pull it together. But let me ask your opinion.
So I think the question is, why are we not moving to something that intuitively seems to be better, which is talking about health? It has better messaging than talking about something that's pessimistic, which is disease. And I think the answer is embedded in our history of medicine dealing with acute diseases, where we need to move expeditiously and we deal with information that's readily at hand. So we've become accustomed in our culture in medicine using these surrogate markers, which are a lot easier to base clinical decision making on an LDL, for instance, rather than examining a patient and getting a detailed personal history. Therefore, I would differentiate acute disease from chronic disease. And I think what we're seeing now is the impact of chronic diseases which have been given short shrift over decades, if not a century of medicine. And in fact, when you look at chronic disease, by the very nature, they're complex. These are not linear problems that you would see with acute diseases. These are problems that have many drivers, key mechanistic drivers, that all have different time scales and various interactions. So it does require, as you would always point out, thinking when you first are confronted with the clinical presentation, and then coming up with a composite type of treatment. Now, to illustrate, and I'll be brief.
Hey, my friend.
We're done.
All right. You have a lot to say. Let's wait. Deepak, I have another question here. Obviously, if we are going to move into primary prevention, there are many factors that make a difference, depending on the country that you are, the district, the community, social economic issues. But I'd like to ask you, and we will talk later, you don't think that the main problem is human behavior? In other words, what I'm really asking here, we tend always to blame everybody in terms of the systems, but all the studies now tend to show that we, as adults, really we do not feel vulnerable. And we have to have a huge change in our behavior and so forth. And I'd like you to point out what is your view of this, because we can talk about anything with 1,000 guidelines, but they come from one side to the other in your head, and that doesn't mean anything.
I think this is really a key question, and I am a believer in personal responsibility. I think if we have patients abdicate that, that's a huge mistake. There's a lot of medicalization of social problems, and I wouldn't want to contribute to that phenomenon excessively. So yes, patients do actually need to take personal responsibility. Not just patients, healthy people before they become patients need to. Having said that, I do think a lot of medical issues, especially if we're talking about primary or primordial prevention, as you've popularized yourself, Dr. Fuster, that concept does require more than just individual action. So it's fine, for example, to say eat more fruits and vegetables, but if somebody really is in a neighborhood where they don't have access to a store with fresh fruit and vegetables, it's not so easy to act on that. So even if they have the will, there has to be some sort of societal support for that. Likewise, we might say walk more, but if you are in a neighborhood where there aren't any sidewalks, that's not so easy to do. I remember one suburb of Cleveland, Pepper Pike. It was actually a wealthy suburb, but nonetheless, there were no sidewalks there, so you couldn't tell people to walk. At least they couldn't walk safely. They could walk on the road, but there were no sidewalks. So I think there are things we could do in terms of urban planning to make cities more friendly for walking, for biking, for things like that. So yes, personal responsibility has to be part of it. That needs to be a message we communicate to patients and to families. But many times it's important to look at social structures, and as you've done in some of your work in Spain, looking at how to mobilize the family, the workplace, to try to accomplish lifestyle modifications, often going to be more useful than just focusing on the individual as a unit and blaming the individual as a unit.
Thank you. We'll talk later about how you approach communities, but let's begin with individuals. We have patients and family members, and the question is, who do you go after and what you do? And I'm going to, Marianne, I'm going to give you the guidelines of European and the Americans about this. Actually, are very similar in grossly. Then there are significant differences we will be discussing. But basically, it seems that the approach is you begin, let's say, at age 20, and this could be debatable, and you go into age 80. And then here you have people in a dividing line at age 40. And then what you do, from age 40 to 80, you apply all these formulas that we will discuss in a moment, which there is a lot of debate about it. to predict events or mortality and so forth. And under age of 40, what you do is you just look at the risk factors, except if the patients have a very strong family history of coronary disease, familial hypercholesterolemia, then you still get into the formula and you act properly. It is interesting that both approaches, which are very general, appear to be very similar in the United States and in Europe. Is this the way you would think and you act? You, with age 40, really the dividing line where you really get very aggressive, and below age 40, you just look at things perhaps in a more flexible way.
I believe the European method of looking at 20-year-olds is much more effective. By age 40, it's a little late. And I think that you've shown even with children, you have to start at 2 and 3 years old to change behavior. So I think that one of the issues is that patients are coming to us with their complaints, but getting primary prevention is to really, especially in certain parts of the country, if you look at NHANES, 50% of people don't know they have hypertension, right? Not the ones that do know they have hypertension who are not controlled. They're not even seeking care. In Harlem, we did a study in hypertension, look at body image and weight, and they think the BMI of 30 or 35 is fine. So they didn't think that that was unhealthy. So it's starting at younger ages that we have to really be more serious about looking at all the risk factors and changing the mindset. Okay. I think one of the important factors of these target numbers, like you said, let's say 120/80, is that it's something that can be expressed to the community. And once they know that that's a goal, I think it's easier to follow.
Kim, we are going to get deeper on this, and actually you wrote about it, and I think basically, and actually there's a difference now between Europe and the United States, but there's a difference in the number. Basically, what you do, you have age 40, and you then measure the risk factors by the American formula or by the European formula, which we will be discussing in a moment, and you predict. According to the United States, you have a risk at 10 years overall of cardiovascular events of more than 7.5%. This is a flag to do something rather aggressively. If you have over a 40-year-old that is below 7.5%, you might question 5 to 7.5%, but less, you just continue to watch such individual every 5 to 10 years. On the other hand, if you are under age of 40, you don't use any formulas, except, as I mentioned, when you have significant genetic, perhaps, background, and then you act appropriately. Now, the reason I'm mentioning this to you is because the European approach is different in the following. The formula in the United States looks at events at 10 years. The formula in Europe looks at mortality in 10 years. That's a very huge difference. And I'd like to ask you, what is most important, you think? Should we look, the guidelines are completely different in terms of the endpoints. And what I'm asking you, what do you think is better, that we know mortality or we just look at cardiovascular events?
I think one of the main limitations of using mortality, I think in the end mortality is would be the gold standard for any sort of treatment in terms of the metric you would want to use for evaluation of it. But it would take years, I imagine, for people to kind of develop the risk and the consequences from whatever exposure that they've had to finally have that end result of death. So in this situation where, as it is already, a lot of our risk calculators are weighted very heavily by age, I think mortality and differentiating or finding a mortality, benefit is going to be more difficult. And you may end up not finding or treating patients or individuals that may benefit from treatment at an earlier time point.
Okay, thank you. Robert, now we come into the formulas. I know you really know all of them, but let me point out the 3 formulas that have been used. First of all, 3 years ago, I had a meeting in New York in December, and I asked people to raise their hands, those who follow the Framingham formula, that at that time 212 was the formula that we use in this country. There were were about 1,500 people there. Do you know how many raised their hands? What would you bet?
Perhaps 5%.
Less than 10. Okay. So, ladies and gentlemen, we all talk about formulas, but nobody follows them. And I think this is an issue, I'm talking about 4 years ago. Maybe today we are more obsessed about it because you get into your phone, you click and you find it. Before was not the case. Now let me talk about with you, Robert, the 3 formulas because, the Framingham, endpoint events at 10 years. And then they follow a series of risk factors. We should not go into it. Now comes the European, which is the so-called the SCORE formula. You know about it. Endpoint is actually mortality, and is based on a number of studies that we were able to pull together. But the one I would really like to talk for a moment is the one in the United States, the so-called pool cohort studies equations, which is the one that has been so much debated. How is possible that an equation that belongs to studies done, the latest was in 1987, is being used in 2016 to address the risk factor profile in this country? Just give me an answer to that.
Well, the studies may have started a long period of time to accrue sufficient number of events to validate the tool, but Paul Muntner published in JAMA and validated the tool in the REGARDS trial, which is a newer, large-scale, multi-ethnic, prospective study, 30,000 people, and the pooled risk equation score was validated in that independent cohort. So I think it's quite relevant and quite representative of the varying ethnicity and races in the United States.
I need other opinions, Dr. Mechanic. I can tell you that the situation looks quite awkward. I mean, if you really look at, because the data in mortality at that time, we already know by the curves, was completely different than today. How can we use that?
I think there's already a bias against using a lot of these tools when you're looking at chronic disease. I'm not as familiar with this particular tool. I know that in the diabetes world and in the obesity world, we do have some risk factor tools that we've tried to incorporate in our clinical practice guidelines, and they have not served us well, primarily because of the data upon which they're based.
Let me ask Dr. Rosenson again. When you go back to the formula, there's another question that I have, and that is today there is a debate that you are very aware of, and that is based on the pure study across the world. It is becoming clear that almost you are very close to the mortality data and endpoint data without doing any blood drawing. You know this story. There's no need to check cholesterol. There's no need to check HDL. There is no need to check the hemoglobin A1C or blood glucose. And you say, where this is coming from? There are lots of studies. It started with Framingham. They really pointed this out 3-4 years ago. And we use this formula, which is called BWAT, and we are going in all our studies. In our studies, we don't draw blood from our children. And BWAT means blood pressure that you do. The issue of the E is actually exercise. W means weight. The A means what type of alimentation you follow. And the T means tobacco. The fact is, the matter is, why in the formula that we use here in the United States, actually weight is not taken into account, alimentation is not taken into account, exercise is not taken into account, and then you have a bunch of blood tests that we are going after. It's because we have too much money to spend and we cannot go the other way. Just give us the answer.
I think that dealing with primordial prevention is focusing on some of the fundamentals, a little bit different in somebody with multiple risk factors, which in aggregate increase risk at 10 years, but also lifetime risk. And the importance of a score is that you're not focusing too much on one risk factor, you're focusing on the multitude of risk factors. Clearly those risk factors need more components in them without overdoing the complexity, and to be able to improve the area under the receiver operating curve. Certainly room for improvement, but I think that the ACC AHA risk score is certainly an improvement.
Dr. Rosendorf, let's now go into the real patients, okay, just for a moment. And we are now have a patient, an individual in front of us who has a clinical cardiovascular disease. And according to such formulas, there's no need for formula. In fact, if you have cardiovascular disease and the patient is under the age of 75, you get your statin and you give the statin at the highest dose you can. If the patient is over the age of 75, you use a moderate statin. How do you feel about it? You don't think this is a shortcut?
You mentioned statin, and that's just part of the story, of course. In patients with established cardiovascular disease, one needs a total approach to all of the risk factors and to all of the abnormalities in pathophysiology that that patient exhibits. So there should be obviously aggressive treatment of hyperlipidemia, if that exists. And I think that the lipid folk are way ahead of the hypertension folk in establishing risk as a primary criterion for establishing whether patients should be treated and to what degree, what intensity. We've not reached that stage in hypertension yet. We're still obsessed with the numbers, and I think that that's unfortunate. The same is true, of course, in diabetes. I think that establishing patient risk is much more important than establishing what the patient's blood glucose is at any particular time as a criterion for initiating anti-diabetic therapy.
Yeah, we will discuss actually this in a moment because I think it's an interesting point. What are your endpoints into what you try to achieve? The question here is that when we look at the reality of all these measurements, in fact, the issue that is really in the literature that is quite questionable, Deepak, is the following. To give a statin 80 milligrams, whatever statin you use, like atorvastatin, versus giving 40, the literature shows very little difference. Why we have to start with these huge dosages that don't care about the endpoint, whatever LDL you reach, but the statin at a very high dose? Because that's the basis of the guidelines here in this country. How do you respond to that? By the way, my questions are particularly critical on issues that are debatable. Otherwise, we can say everything is fantastic here. So this is the reason why I try to address this panel with the issues that really are questionable.
Yeah, again, a terrific question, and I think it depends on the setting, but for primary prevention, if that's what we're talking about, I think it's better to get the patient on a dose that they're actually going to take, where the risk of side effects is lower, and I don't know that it's necessary to come out of the gate blasting them with the highest possible dose of statin. And I think it might be a little bit different in a secondary prevention post-ACS population where there may be some benefit to very early delipidation, sort of as Miracle suggested, though it didn't totally prove with atorvastatin 80. But in the primary prevention, it's much more important that the patients stay on it and not have side effects. So I think there's always the opportunity to increase, but if you start at a very high dose and they have a lot of side effects, they may never go back on any dose.
Yeah. Thank you, Don. I present to you 3 patients that according to guidelines, we should give a statin at a very high dose. And this is actually primary prevention. We are not dealing with coronary disease. Patient number 1 is a patient who has diabetes. Patient number 2 is a patient who has an LDL cholesterol more than 190. And patient number 3, the projection is more than 7.5% of events in a period of 10 years. Is this what you do with your patients?
In essence, that is what I do with my patients. I think that those are very good guidelines, basically, in terms of that. I used to use the ASCVD score, the AHA, but it's not as good as when you throw in a coronary calcium. As you know, the MESA risk calculator that uses coronary calcium has moved the receiver operating characteristics out a whole percentage point. So that's the way I sort of tell, because I make mistakes if you use these formulas. You can put in everything, and then yet the coronary calcium score, you think they're high risk, and their score is 0. And they don't have any plaques in the carotids. And so those are fair as predictors, but without looking at the vessels themselves, I think we miss a lot.
We'll talk about imaging, but Jeff, I want to ask you the same question. You have a diabetic patient or you have a patient with an LDL more than 190, or a patient who has more than 7.5 events per 10 years, are you giving an 80 milligrams of atorvastatin or 40 milligrams of Crestor? Or are you giving these kind of dosages to start with? Primary prevention.
Right. So I'm not sold yet on the latest ACC-AHA with the score. I do treat to target, and I do use LDL levels, but admittedly, I still think the issue is unresolved and requires more data. Patients with diabetes, however, represent a different category, and when you look at the entity of metabolic syndrome, you realize there's a lot of interaction among not only diabetes and dyslipidemia, but diabetes, hypertension, weight, and dyslipidemia. And in fact, weight loss is a powerful tool in managing this type of disease and actually changes your thresholds for decision making.
Well, you just touch into the next question. In fact, the next question was, can we do something else? That just giving a drug at the highest dose on somebody who their weight is 270 pounds.
So I think the metabolic priority in that situation is the weight. I think we're going to await, no pun, await more information, probably from big data and registries, to solve this. When you look at metabolic syndrome, there was a lot of debate whether it exists. I believe that it is an incredibly helpful tool, and I believe of the 4 component risks, and notwithstanding the fact that there are innumerable residual risks, that weight loss is the most powerful, and the eating pattern that's used in tandem with calorie restriction is the most powerful. Physical activity as well.
Deepak, before we go into the details of each of the risk factors and the endpoints, I'd like to ask a general question. It seems to me, by listening to what you said, that you agree with the fact that we should use both, the overall integration of all the risk factors, and then looking at the endpoints. And that is, see if my LDL can be less than 70 or 70 when it is a high-risk patient and so forth. So I want to be very sure that I understand you. You believe on endpoints as a compromise to the whole high dose, wherever the LDL ends up.
Yes, I mean, while I believe in reducing risk globally, I think having measurements is useful in practical day-to-day life. And so LDL measurement, I think, is useful, if nothing else, to make sure patients are adhering to therapy. But beyond that, I do think the values and percent reductions matter. I think the majority of data suggests that. So I would never overly focus on a singular number, but I do think measurement is part of what we do as physicians and part of what can motivate patients to do more.
Okay, so now we are going to go into measurements, since it seems that at least is a possibility. And we have not only LDL, we don't have only high blood pressure, we have all sorts of things. So we're going to talk into 7 risk factors, and I really like to go into details. Larry, you're awake. Good for you. Let's start with hypertension. Okay, let's start with blood pressure. And before, let me say a few things and see if you agree or disagree. First of all, those of us who sit in the board of JAC, we are a little bit tired of having almost every week a new paper on blood pressure that always is the same. So many millimeters of mercury, the patient is age 55. If it is below 120, should be 130, and the patient is, and when in fact, in this country, 50% of the people with high blood pressure are not treated or not properly treated. You don't think that we are really out of line here?
Well, I would never say that Jack is out of line, but I'm going to answer that by saying, yes, we are not where we should be, but in 2 senses. One is the goal is maybe not as important as getting near the goal. And second is, in primary care, the changes in this country will depend upon, I think, 2 things: education of the public and out-of-office care by telemetry and the techniques that are being explored both here and in England with getting the patients to self-care and self-titrate. I think that's where the answer is.
Marianne, you are very expert on statistics. Let me give you a statistic of a study just published that has shaken up the world, and this is the SPRINT trial. Okay, the SPRINT trial is exactly, I don't want to read the abstract of the paper, but I will tell you what it says, published in the New England Journal of Medicine very recently. The SPRINT trial says, using two approaches to blood pressure, one that they call very intense, trying to get a systolic pressure less than 120, and the other less intense. And the results were the following, that the intense approach had a risk reduction of 25% of very hard events compared with the less intense, in which the average blood pressure, by the way, was 140, and the other, the average was 125. It was a 25% reduction. Now let me tell you the absolute reduction. It went from 6.8% in the non-intense group to 5.2% in the intense group, and they call this 25% reduction. Now let me tell you the side effects. Significant and serious side effects were 4.7 in the group treated aggressively versus 2.5% in the group not treated aggressively. If I use the same approach, it's an 88% higher risk of a problem in the intense group. But in the New England Journal of Medicine, they only use absolute numbers on this particular one. They don't use the relative, and they use relative on the other side. I look at this data, and then I will discuss the HOPE study in a moment. So what do you think about it? What is your reaction?
It's a typical way of describing the benefit is in a relative risk reduction, and the absolute numbers are always smaller. But I think another part of that trial, when they looked at how many people would be affected, even with that level of reduction, it would be 660,000 deaths that would be reduced, and even a greater number of events that would be reduced. So I think it's common in all trials to look at that, and it's for the reader to understand the differences. But I think that when you look at the absolute increase in side effects, that was the overall group of side effects, not the hypotension and falls. If you lump them all together, yes, there was a higher rate, but when you looked at them individually, there was not a significant change between the risks. So I think that they were reasonable in showing the results.
I like your conservatism, but Larry, I go back to you. The HOPE study, just published in the New England Journal of Medicine, you know the results. And the results are that the side effects are higher than the benefit when you are intense. So tell me, how do you pull all this together? It's easy to say. What I'm trying to say is that we should treat blood pressure as much as you tolerate whatever drug you give. And there is no such a limit, or there is no such a figure for everybody. That's basically what I'm trying to say. And I like you, how do you respond?
Well, the HOPE is a great study to read, and I think should be understood because the group that had the highest blood pressure benefited from blood pressure reduction, whereas the other two groups did not. And I think the important message is, I guess we'd better really measure blood pressure before we treat and not make this a public-wide intervention. I think this was a surprise to Dr. Youssef and his colleagues. A different pattern was seen with lipids, which others will talk about perhaps, but it came back to basics. Make the diagnosis, hypertension, then you know who to treat.
Okay, I'd like you to give a message to all of us today, and that is based on all this discussion. What is the ideal blood pressure? I mean, you have a patient in front of you. Don't tell anything theoretical. You have a patient, you have 10 people in front of you, and I'm asking you, how are you going to manage? And what level are you trying to achieve?
Always a tough and provocative question. The lowest blood pressure that maintains the health of the patient, We want healthy people with lower blood pressures, as if we didn't need medication because we were lucky to be born with a lower pressure. But that's what I want. I don't want the side effects, which has a little bit been overblown because there are few in most patients and none in some patients. But we want to preserve the health at the lowest reasonable pressure.
Well, I think this is wonderful what you say, because basically this is personalized medicine, and we talk so much about it. It's the ideal case. Is not correct?
I agree.
Good. Okay, Jeff, I'd like to start on diabetes. And first of all, Deepak, let me ask you before I go to Jeff. Do you think we cardiologists know about diabetes, or we know very little?
Well, I think the answer is both. I think in practice we probably need to know more about diabetes and diabetes treatment than we do. But I think cardiologists do deserve some credit, because we've really caused the field to leapfrog forward in terms of clinical trials. That is, the trials that have really focused on cardiovascular outcomes of diabetes drugs were launched largely by cardiologists, working in concert with endocrinologists, of course, but it was really that large cardiovascular outcome experience that clinical trialists from the cardiology world have now brought to the endocrinology world. And I think we've learned a lot. We've learned a lot about cardiac-specific outcomes, but also just overall safety, or in some cases lack of safety, of different diabetes drugs. And I think that's a major contribution. And there was a lot of criticism initially about these wave of cardiovascular outcome trials. Many in the endocrinology community actually said it's a waste of time and money, and research dollars could have been spent elsewhere. But as it turns out, now we're actually finding diabetes drugs that reduce cardiovascular outcomes, including cardiovascular mortality, such as the SGLT2 inhibitors in the EMPA-REG trial.
Well, first of all, I will go to Jeff. It seems to me that we all talk about diabetes because it's a huge risk factor, and we know figures. If the diabetic patient has heart failure, no heart failure, it's bad to have diabetes in multivessel disease, better than if you don't have. We all know that, and we feel pretty good talking about. Now, the question here is twofold. First of all, a number of trials done on diabetes and the drugs given to diabetes were looking at the wrong end, which is intimal medial thickening. And you know the story. I could tell you 3 drugs that were out of the market that are coming back because imaging was used wrongly. Intimal medial thickening doesn't mean anything. It has nothing to do with atherosclerotic disease. But once I say this, there's a second issue I want to see what is your opinion. It is my understanding by reading the literature that today about 50% of the diabetics is like hypertension, are not being treated or are not treated properly. So again, we can get into endpoints and scratch our heads what is the endpoint, but half of the population that have diabetes are not treated. Is not correct?
That's correct. And this is an issue of disparities of access to healthcare. It's sort of like the obesity epidemic also, where you see just an overall aggregated prevalence rate, but you see obesity, for instance, going up in certain subsets like pediatric to super obese Latinos, African Americans, et cetera. And the same you see for diabetes with disparities in access to care. The other point is, this is really a socioeconomic and political issue, not so much a medical issue. With insulins costing hundreds to thousands of dollars a month and new incretin-based therapies and SGLT2s that we can't get approved for patients, it's put a lot of pressure on us who are writing these guidelines to come up with practical guidelines. So the yin and the yang are that on the one hand, we want to come up with the most ideal guidelines that don't expose patients to hypoglycemia risk, devoid of sulfonylureas and de-emphasizing insulin, emphasizing incretin-based therapies and SGLT2s, where now we do have these cardiac benefits, but these drugs are not available. So not only around the world where you have some low and middle income nations that can't afford it, but even here in the States, our patients do not have access to state-of-the-art diabetes care. And that is having an absolutely upsetting effect on prevalence rates and downstream rates of cardiovascular disease, which are dependent on glycemic control.
Deepak, I think this is why we are so behind in primary care. In fact, there's a huge gap here, huge gap. People are not treated properly. And I think the other issue is, since you are not educated that this is important, then the whole thing is like catch-22. It gets worse and worse. Well, I'd like to ask now Dr. Rosenson, who's very quiet there, and I'd like to to present to you a couple of things related to how the discussion is going. First of all, it seems to me that we are having a huge gap here. First of all, 4/5 of the world is middle and low economy, and 80% of the infarcts happen in these countries. And actually, when you look at the access to what was discussed a minute ago, it's not just 50% are not being treated. According to the Pure study, 75% of people with hypertension and people with diabetes are not being treated. Now, what in the world can we do? Because we are sitting here with all of our patients coming to our offices, and we feel we are doing a great job, when in fact, I think we are absolutely irresponsible. Because we have a voice, and we can have an influence, and the question is, what are we doing?
I think there's several factors that are contributing to gaps in care. There's a big issue in terms of education. We reported in JAC that only 27% of individuals through 2011 were on high-intensity statins, even though that's a Class 1A recommendation. That number has improved. Data we presented at ESC, it's up to about 55% in seniors and up to 70% in market scan, paper we're putting together now. So I think that the guidelines have made a big difference in terms of the cholesterol guidelines, the evidence base. I think other issues that we don't pay enough attention to are treatment adherence. We have data that we're submitting showing the importance of treatment adherence, evidence-based therapy on cardiovascular outcomes, and if you have gaps in your treatment, poor adherence, your risk of recurrent myocardial infarction, hospitalization for coronary disease, and mortality are increased. So those are important factors. I think that in a very busy, time-pressured clinic that is often worse elsewhere around the world, that people are not taking the appropriate family history, the dietary assessment and guiding on exercise. I think these are critically important issues for the physician to be involved in and not to displace to someone else. So there's, I think, a multitude of ways that we can intervene on this crisis. And if you go and visit countries elsewhere, and you see we complain about our overload and our inability to spend time with patients. It's much worse, in India, the Far East, where they're seeing 50, 70 people, a day, sometimes 100 people a day. And, how can you get the message across to the patient when you're spending, 2-3 minutes with each and everybody? Everyone.
So it's interesting because now that economics are driving to go towards primary prevention, the process is what is the infrastructure by which this can be done? What is the behavior of the people? And it's a complete paradox. It's amazing. I'd like to ask the same question to 3 people, actually, to you, Kim, and to Donna Smith, and to Jeff Mechanic. Now, if you look at the last tables from the WHO, and you have to pick up the #1 cause of mortality and morbidity in the world is diet. I mean, this is absolutely why? For 3 reasons. One is the reason of the obesity, calories. The other is the reason of salt. We are talking about a lot of salt. It now is the issue of the sugar. And in fact, when you look at all together, some people don't eat at all, and some people eat the wrong things. And that's basically the #1. So I'd like to go over the healthy diet characteristics. And once I finish, which will take 30 seconds, the question is why we are ignoring that. And the healthy diet characteristics are saturated fatty acids, less than 10% of the total energy, calories. Trans-unsaturated fatty acids, less than 1%. This is what we should not do. Salt should be less than 5 grams per day. The great debate of salt has been between 2 and 4 grams. If you go 5, there's no debate. I think it's very important because there are lots of articles and people are talking always in between. This is important. The next one is 30 to 45 grams of fiber a day. Fruit, more than 200 grams. Vegetables, more than 200 grams. Fish, 1-2 times a week. 30 grams of unsalted nuts. and then consumption of alcohol should be 1 glass for women and 2 for men, because to metabolize alcohol in women is much more slowly in the liver. And then to avoid completely, or try to avoid the sugar type of soft drinks. Okay. Now, is this the problem, that this is not appetizing, this kind of thing? Or what is going on? This is the Mediterranean diet, basically, what we are describing here. Kim?
I think number one, when you ask
Can
a
you
question,
put the microphone closer?
when you ask a question about diet, it's just that question alone, it kind of simplifies or oversimplifies the problem. Because when you think about diet, it's very multifactorial in terms of what kind of defines it and what impacts an individual's diet. It includes kind of cultural issues, includes resource issues, it includes just looking at kind of the infrastructure and kind of what's available in terms of what's offered. And I think that's why it's such a complicated issue. And when you pose it as when you just call it a diet by itself, it sort of oversimplifies the problem. And it gets back to, like when you're thinking about true risk factor modification and kind of regression of disease, and this idea of the primordial prevention, that's what makes primordial prevention so complicated, because it goes through and it affects so many different parts.
It's a cultural issue. Actually, Don, we are having a project with lots of children, and it's amazing to see when you teach children about the diet, and we spend 70 hours over a 6-month period, exercise and diet. They capture these even years after you have the intervention, and you really change that culture that you are mentioning. Do you think it's possible?
Well, hopefully you can change the adult patterns for teaching children. I think one of the things you read, that whole dietary list, it's meaningless, because nobody thinks in terms of grams of salt or amount of saturated fat. You think in terms of foods. So when you talk to people, you have to get down to specifically what they're eating. As you see, people are taking coconut oil, being promoted as a saturated fat for wonderful things. I can't believe how many people with coconut fat are frying all their vegetables in that. That was outlawed here in New York City, 30 or 40 years ago? And somehow it's come back. Egg yolks, they've come back again. And 3 or 4 may be okay, and there's some studies that show it makes no difference, but there are other people that the LDL just goes right up. So all I can say is the guidelines are great, and if you can think in terms of grams of things, then that's great.
Well,
but I think you have to think more in terms of food and have people turn those into foods, basically.
I take what you say, but let me go to Jeff, though. I never tell a patient, ever, 200 grams of this, 300 of that, 5 grams of that. But you take color things, it's fruit, and it's legumes, and it's vegetables, and olive oil. You can say these things, and so forth. The point that I'm really getting at is to industry now. And that is, to me, to change the culture is going to be very difficult, as we mentioned, except I still believe we can do a lot with children. But I don't think you can change the culture of a given country in general, certainly the adult population. But I believe that all the industries that we are beginning to be successful is the food industry, because it's not an all or nothing like the tobacco industry. You can say they're dropping the amount of sugar. Certainly in Europe, they're dropping the amount of salt. They're dropping the amount of trans fats and so forth. So I think the question that I'm really driving is not the guidelines for the individual, because I don't care, but it has to do with the concept and how we address the food industry.
So that's precisely correct. The issue now is not so much about the science. It's a little bit about nutritional messaging and health literacy, but it's primarily about, and this is controversial and a sticky subject, but this is about food politics and legislation. I personally am a believer that physicians have an obligation not only to work within the community at a local level, but to press very, very hard at the governmental level. And I do think a lot of these things need to be legislated. Obviously, that's a contentious point. The American Civil Liberties Union and a lot of other advocacy groups would oppose that. But we're dealing with a profound adversary in the food industry when you look at the inclusion of sugar and breads and food pyramids and what HHS had to go through to change this to my plate, and a lot of the other contamination and corruption in what's being disseminated, at least to the American people, and the influence of Monsanto and other industries. It's really egregious. And I think physicians owe it to ourselves, for our patients, to band together. I don't think we can do it individually. I think that societies really need to form a consortium. I don't even think an individual society can do this themselves. I think there needs to be a consortium. There needs to be a concerted effort on Capitol Hill. We're trying to do it. It's taken 4 years to get a diabetes bill through, and we're barely there. We have obesity bills that are getting beat down right and left. And I think we do have power, but we need to rally it.
So, Dr. Rosendorf, we are going to finish this, and we have been talking about a subject that in a way is becoming very important, but is very frustrating in the sense of what we can achieve, or what we are achieving. Now, can you give us some kind of a message of what is your views about primary prevention in the way we have discussed? Or promoting health, put it in a different way, more positive.
It's impressive that we've been able to discuss this at all sorts of levels. We've discussed this at the population level and at the community level and the individual level. And I think the problems are not really identical in all of those three levels of organization. In terms of the population dynamics, it really depends upon the culture, the ethos of the country, the political structure, the degree of socioeconomic development. All of these are factors. But things can be done through legislation. An example that springs to mind is the reduction in the salt content of processed foods in the United Kingdom that was legislated as a result of very active and aggressive lobbying on the part of physician groups. So it's not entirely a hopeless proposition. The challenges in low and middle income countries are really enormous. And it's not the food industry there, because these people by and large don't eat processed foods. But it's really a question of getting education to the population, and mainly educating the legislators to institute appropriate health measures. As far as individuals are concerned, yes, I still believe that the numbers are useful, but I think we are moving away from our obsession with these numbers, the numbers at which you institute treatment for each of these three conditions, the numbers that you have as goals for each of these three conditions, and are moving towards a model in which the risk of the patient, in this case the cardiovascular risk, is the primary driver for whether or not to institute treatment, what to use, and the dosages to use, and how to upregulate or uptitrate the dosages as necessary. One quick example, if I may, of that from SPRINT, which you were very dismissive of, Dr. Fuster. But one of the really impressive outcomes from SPRINT was that the lowest tertile of baseline blood pressures, that is in the low 130s, showed the greatest benefit from lowering their blood pressure to below 120. And I suspect, although the data have not yet been published, that these are the highest risk patients from the point of view of cardiovascular risk. So 132 millimeters of mercury, a patient comes into your clinic with that level of systolic blood pressure, you'd say, you're fine, you're going to live forever, go away. But SPRINT tells us that if that patient has other high cardiovascular risk factors, and of course age over the age of 75 is one of those, then that blood pressure could be lowered with benefit to the patient in terms of hard outcomes.
Thank you very much, Deepak. I want you to perhaps close the session, and I'm going to present to you the following hypothesis. It seems to me that the field we are dealing today is very complex, and the complexity is manifested by the fact that we are not accomplishing a lot on obesity, we are not accomplishing a lot on diabetes, we are not treating hypertension. So that's really the frustration. Now, can you give us a message of what should be done? We could have spent the whole hour talking about, I don't know, the role of diabetes in microvascular disease or the role of this and that, but I think the problem is so huge that I'd like you to say a few words about how would you approach it.
Sure. Well, it's primary prevention is difficult. It's always easier to treat disease than to prevent disease, and that's the core challenge. It is also harder because there's less consensus, and I think the medical profession and then the media secondarily play into that. That is, there's so many contradictory, confusing messages that come out. It's impossible for physicians, let alone for patients, let alone healthy people, to know what to do, because once they're getting a message, fat's bad, no, fat's actually not bad, no, it depends what type of fat it is. Same with the salt and sugar debates, where a lot of times a layperson doesn't know the finesse and doesn't know the difference between whether it's 6 grams we're talking about or 1,500 milligrams. To them, it's just a confusing message. Egg yolks, one year they're good, another year they're bad. So there's so much information out there, much of it observational, much of it contradictory. It really creates problems. Sprint, there's been such a debate around it. I actually think it's overshadowed the point you made, Dr. Fuster, that there are a lot of folks walking around with blood pressures of 160 and 170, that we need to worry about, as opposed to whether the optimal target is 120 and 140. I can't leave that trial, though, without at least pointing out there were some issues with how blood pressure was measured in that trial that were different from other trials. So what they're calling 120 in our office practices probably wouldn't be 120, it'd be 130, plus or minus a few millimeters of mercury. But that, again, adds to the confusion. So that's part of the problem. I agree that legislative action and policy change could be helpful, but that's if we could agree on what that should be, which could be challenging. I mean, here there's been a lot of consensus, maybe because it was late in the day. But in fact, if you survey the broader physician community, there isn't consensus on any of these issues: salt, sugar, how to measure them, how much there should be in the diet. So I find it very challenging. I think from a bottom line perspective, the keys should be to focus within the primary prevention universe on those patients where there isn't controversy. That is, people that are walking around with blood pressures of 160 or 170 or LDLs of 160 or 170. There, I think those people are at very high risk, and reducing those numbers will produce real clinical and economic benefits. For those patients, people that are at lower risk where there's uncertainty there, I think the focus has to be not so much on medical therapy, but lifestyle modification. And some things are certain. In any animal model that's been studied, caloric restriction increases longevity, and that applies to humans as well. So yes, there are a lot of debates about the percentage of carbs, glycemic index. You can get into all sorts of debates, but what we can all agree upon is people that consume too many calories are going to do worse than those that restrict their calories. Yes, I think the constituents of that diet also matter, but the overarching message should just be eat less. And then, of course, within that, to eat healthy. So focusing on areas where there's consensus, maintaining a good body weight, getting people in the habit of measuring waist circumference on a regular basis, getting people to weigh themselves daily. Those sort of efforts, I think, in terms of primordial prevention, can do quite a bit. So where there's consensus, I would say we should act, make it clear to the community at large, yes, there's consensus, there is no debate on these particular issues. That could go a long way. So I think as a medical community, we have to be honest with ourselves and with the public and say, yeah, there's some areas of controversy, but there are actual areas of consensus, and to not make it seem like those areas of consensus are in fact controversial.
I think you are right. Simplicity is the name of the game. And as simple as you get, this is when we give a drug and you understand what that drug does, we feel quite comfortable. We don't have to ask more questions. This is open to questions or comments. Yeah, Dr. Friedman.
So when people get older, they obviously have bigger swings in blood pressure, stiffer vessels. They have low blood pressure, they have high blood pressure. And I have all my patients keep blood pressure diaries. And you know, late at night you're looking at a blood pressure diary, you see a 160, a 140, 120. And then you say to yourself, guidelines, and then you say to yourself, you gotta be kidding. So, I mean, what I do in my practice is I try to get as low as I can, but if they're showing up with 90s over 50s, I let them live with high blood pressures. So it's just, that's, to me, the whole discussion of the ideal blood pressure is difficult to be, it's not useful for that reason. Younger people, I think they buffer their blood pressures, and it's a lot more productive.
Comments? Larry? Oh, Deepak? Yeah.
No, I was just going to say, I mean, I agree with your observations, and I think that's a point several people on the panel made, that these decisions need to be individualized. There are certain statements, again, on a population level, population health we can make, you know, for the extremes of high blood pressure, but then within that range of normal, you know, is lower, better, those have to be individualized. Certainly if there are side effects, then it's time to back off. I'm a little hesitant with Dr. Rosendorf on the panel to say too much about blood pressure, but I'm a believer in the J-curve phenomenon. I think that that is likely real and not just confounding from other issues. In some studies, there's a bit of confounding as well, of course. I think it's more true in people with coronary artery disease and obstructive coronary artery disease than in healthy people. I think you're right. In a young, healthy person, you can pretty much do anything and they'll be okay. But it's really when people are older and or sicker that these decisions matter more. So I think the numbers do matter. I think trying to figure out, you know, what the ideal blood pressure is, again, on a population health level, is less important than just identifying people that have clearly a high blood pressure. But again, within that population of people that have blood pressures, say, in the range SPRINT tried to study, it is an important question because there are lots of those people. So even though the individual risk of being at a slightly high blood pressure is low, there are millions, if not billions of people like that. So I think those questions matter, but I think the answers to those questions will require a lot more research.
It's interesting, Sandy, there is a paper coming out next week, which is about the impact of variations in blood pressure is as impactful as a high blood pressure. In people who have normal blood pressure, but there's a constant variation, and I do the same you do. I take the blood pressure of all my people once a week, every day at a different time, to get an average and to see how it fluctuates. But this is coming out, so it's an issue. Comment?
Everyone talked about systolic. Dr. Bott, you had a recent article on diastolic blood pressure being too low and harmful in coronary disease. Can you comment on the diastolic pressure?
Sure, thanks for the question. And it was actually an editorial. It was original work that was done by the ERIC investigators, the Atherosclerosis Risk in Communities. And what they showed was that low diastolic blood pressure, well, first of all, they showed that elevated blood pressure is bad for you in terms of clinical outcomes. So that is confirmatory. But what they also showed that I thought was incremental in terms of our knowledge and understanding of these issues was that low diastolic blood pressure, say less than 70 and especially less than 60, also seemed to be associated with an increase in cardiovascular outcomes, especially in the context of an elevated pulse pressure greater than 60. So that created a double whammy. And I think it's probably real because, as everyone in the audience knows, coronary perfusion occurs largely in diastole, so there's a theoretical basis for why dropping diastolic blood pressure too low, especially in someone that has atherosclerotic disease, microvascular dysfunction, all of the above, could backfire. The interesting thing these investigators did in this work published in JACC was measure troponin levels at baseline and a couple of years into the study, and again found an association between low diastolic blood pressures and elevated troponin levels, and then a correlation with adverse cardiovascular outcomes. Of course, it's all observational research. You can't always assure that all confounding has been controlled for, but they tried to control for confounding as best they could. So it created a pathophysiological argument that seems sound to me. Drop the diastolic blood pressure too much, especially if the pulse pressure is high. You know, there's some leakage of troponin that's occurring, and then that does in some way over time lead to coronary ischemic events. So it made a lot of sense to me.
The leakage of troponin began at levels below 55 millimeters of mercury diastolic blood pressure. So it seems from that it's reasonably okay to go down to, but not below 55 to 60.
Okay, I think we should. Well, look, thank you very much. I think it's an important topic. We tried to address it the best way we could, and I hope that in a few years from now we'll feel much more comfortable. Thank you.